Hey, while we're doing that, Dr. Khan, will you say something? Just want to make sure that we can hear you.
Testing.
All right, perfect.
Oh, you've got that microphone set up that's that deep, resonant
We won't miss a
voice.
thing.
If I want to get really deep, I probably really close like this,
There you go. There you go.
but I'll not do that.
Oh, it's nice to have that resonance, though. There's a voice of, oh, I need to listen to this.
All right, folks, we are live.
Hello. We're live. Hello, everyone. Welcome. It is 4:00 Pacific, 6:00 Central here in Costa Rica, 7:00 on the East Coast, midnight in Dublin, 1 a.m. in most of Europe. No, midnight in London and 1 a.m. in Milan and Warsaw, 5:30 a.m. in New Delhi, 10 a.m. in Brisbane, Australia, 1 p.m. on Wednesday in Auckland, New Zealand, and it's Facebook Live. Tell us where you're from and what time is it there. It's always great to see, tickles me to have people in from all over the world. And I'm really excited to be here today with my friend, Dr. Peter Kahn, who is always a joy. As I am to gluten, Dr. Peter is to your brain and nervous system function. And that where he dials in his focus. And, for example, he wrote the first book I ever saw on the vagus nerve and what to do with the vagus nerve. And I am just really grateful he's here. We're going to have lots of pearls for you tonight. So once again, tell us where you're from, what time it is there. Wendy says, hello, Claremont, California, 4 p.m. Hey, Wendy. Tracy's in Florida, 7:00. Olga's New Jersey. Debbie says 11 a.m. in Newcastle, Australia. That's right. There's different time zones. Sorry, Debbie, didn't mean to leave you out of that. Cheryl's in Buckeye, Arizona. It's 5 p.m. I hope that doesn't mean that you are an Ohio State town, because I'm from University of Michigan, and that's not okay. But so
That's Buckeye in Arizona. It's a town in Arizona.
That's right. I've never heard of that town before. Thanks for being here, Cheryl. And Jane's in England. Jane Corrine is in England. Hello. Thank you for staying up. I know it's late. And kudos and greetings to Gracie. Where's my brain tonight? Mom's name is Quincy, the Benson family in Iowa. They're here every week, and it's nice to know you're here, guys, and thank you so much for being here. So, Dr. Peter, welcome. Great to see you here.
Thank you so much for having me. It's an honor and a privilege to be with your community and be with you as well.
By the way, Dr. Peter's a CGP, went through the course, scored one of the highest exams ever on the course, and includes wheat-related concerns in all of the patients that he sees. So let's just do a deep dive. Let me ask you, what are you interested in these days? What's caught your attention these days?
It's interesting. The more I study this, and a lot of it has to, it really started with a lot of your teachings. Back in the day, we learn stuff, we go to seminars, and a lot of times you go to these seminars, the experts are just saying, hey, you do this and you get that, you do that, you do that. But, you're the first one that I saw that was really directly quoting research, quoting from peer review, showing the actual, paragraphs on the peer review, and then explaining it, what that means. And that really got me to understand, science and how to read research articles better. Although in undergrad, I did a lot of that too, but it was for exercise physiology, which is my undergrad major. So as I continue to study, I just see an explosion of research more and more in the field of immunology. Mm-hmm. And, I kind of put out this message of the brain immune gut connection. And I think the I is a capital I in that big connection there. Really so much comes down to, signaling and messaging and cytokines, how that really promotes, all the different things. So hopefully today I can shed some light about how brain and immune system and the gut kind of really integrates together to create health and disease. And really, when we say brain, immune, gut, we can't really leave out, I almost feel like we need to change that, or I want to change that term to brain, immune, gut, hormone, metabolism, detox, access,
Right. That's great. That's great. Yeah. And I've got a couple of questions for you on that. But before I do, Christina's in Costa Rica and she says, happy Valentine's Day. Thank you, Christina. And to everyone out there, a happy Valentine's Day to you too. Hope you make it a sweet day. And don't forget who your greatest sweetheart is, and that is yourself. And do something nice for yourself. Maybe it's just a thought, maybe it's just some simple action, but don't forget to treat the Valentine inside of you that takes care of you. Really important, and something that I haven't heard too much being addressed on Valentine's Day. So, Dr. Peter, I've often talked about this thing of our ancestry, and that our bodies are actually a survivalist body, that for those that didn't have the right response to the environment, they died. So if we go back to and if they died, they didn't reproduce, so there's no offspring carrying that genetic linkage forward. And if we go back to our ancestors before agriculture, they were nomads. They followed herds. They were always looking for food, and they got shelter wherever they could. So number one concern was food. Number two was shelter. Number three was safety. Number four, reproduction, in general, that order. And what is it that we've inherited from our ancestors that most people haven't really thought about today, that has to deal directly with this gut-brain immune connection?
I wonder where you're going with this.
Yeah, I know. I've thrown a question out there that's why is 70% of the immune system in the gut?
Okay, yeah. So, really the gut, and I would actually extend that, Dr. Tom, to all mucosal surfaces, right?
Yeah.
And the mucosa is that inner lining of your mouth. If you see inside the lining of the mouth, it's like pink and moist tissue. That's the same tissue basically throughout the entire GI tract, right? If you ever see an endoscopy, picture of endoscopy, it looks just pink and moist, just like it. Colonoscopy, pink and moist. The sinus cavity, pink and moist. Vaginal canal, pink and moist. So these mucosal surfaces are basically a route of entry where things can come in from the outside to the inside. So that's right. Your sinus through the nose, the mouth through eating and various things. So even the lung through breathing. And because it's interfacing with the outside world, you have to have these defense system built in to, eliminate pathogens, to detect things in the environment that may be harming you. So this is part of our survival, right? I mean, if you think about immune system, nothing is as important to our survival as the immune system. I mean, its job literally is to kill pathogen. It's like, it's us or them, man.
Well, how often are we exposed to pathogens? People don't know. How often are we exposed to pathogens?
Well, I mean, so I think we have to also define that, right? We have microbes and we have pathogens, right? So the microbes are things that are naturally in our body, on our body, right? The microbiome, the skin biome. Mm-hmm. So we have more germs on our body than we have human cells, right? Just take the number of human cells, multiply that by a factor of 10. That's how much bacteria you have. Multiply that by another factor of 10. That's about how much virus you have. So it's really not practical or it's not accurate to think of a sterile human being that has no microbes.
Right.
But when we say pathogen, we're typically saying, microbes that can cause this disease, pathogenesis. Mm-hmm. And so some pathogens are more capable of causing disease. Some pathogens are very predatory, meaning they want to reproduce at the expense of the host so they can kill us, like right. TB, typhoid fever. That's pretty bad stuff, and you want to kill them. You want to get rid of that. But then there's other microorganisms that are kind of coexist with us. They're symbiotic with us, or they're opportunistic, where normally they don't cause problem, but when our immune system is suppressed, then they kind of grow, start to reactivate. So I think we have to have a healthy understanding of a comprehensive understanding of, okay, not all bugs are bad, some are bad, and the immune system's job is to really keep that bistable balance between the neutrophils, our immune cells, and the pathogens. So it's really,
let me ask you here, and I know I've thrown a curveball question at you because I really want our people to understand how often is our body being exposed to potential danger in terms of bacteria, viruses that we're exposed to.
Well, I would say the answer to that is constant.
Exactly.
We're constantly exposed.
Exactly. And we don't know this.
Right.
We don't know that every time you walk into an area and it smells, that is bacteria that you're inhaling up through your nasal epithelium up to the memory center of the brain. That's why you always have to close the lid before you flush the toilet, is because just go on Google and type in video of toilet flushing, and you see all of this bacteria. They have certain lights that can show that every time you flush a toilet. And so or when someone stinks up the bathroom, what does that mean? It means you're walking into a room where there's lots of bacteria in the air. And nobody likes to think about that, but you have to appreciate your immune system is working 24/7 to protect you. It never lets up. I mean, I was startled when I learned from Jeff Bland, Dr. Bland, the founder of functional medicine, that we have an entirely new immune system every 2 months. Every immune cell is regenerating constantly. That's the human condition, is that we always are being exposed, always. And we have the innate mechanisms because our ancestors passed on the genetics in the lineage to protect us so that we always have protection. And it's only when we really overuse that system, abuse that system, that we start having immune system dysfunction. So that's like a big picture concept. It's like, what? Oh, what? Oh. But now you understand. And so you always want to be a little more protective of your home environment so that you don't have smells in the house. You walk in, oh, it smells a little musty. But then in 5 minutes, you forget about it. Well, you're still breathing it. You've just adapted to it, right? So that you want to identify, where's that musty smell coming from? And if it's the garbage that hasn't been taken out in 2 days, take the garbage out now. Or that's a honeydew. Honey, take the garbage out, whatever it takes. But I want people thinking a little more about protecting themselves and their environment. So let's go to the gut now and the brain connection, because that's really in your area of expertise. And let's just talk a little more. How can people enhance their brain gut connection so that the messages from the gut are supporting a healthier functioning brain? Absolutely.
Yeah. And, oftentimes there's this talk about the bidirectionality of brain gut axis, right? It's the brain does have a huge role in controlling digestive function. And then, your gut, through the gut microbiome and various peptides, also has a huge role in communicating back to the brain about the status of the gut. But let's just take a top-down approach. So your central nervous system, your cortex, your brain, is responsible for picking up environmental cues. All right, we have afferent signals coming from the environment through sight, smell, touch, taste, and hearing. So then these signals telling us how to respond to our environment. If we hear a tiger, then we better run away. We feel cold, better put on a coat. If we see fire, better go put out the water or run away from it. So our brain is basically just a big old sensory organ. One of our neurology teachers said, it's your brain basically like a big antenna. to pick up the environmental cue. So then we can interpret that cue and kind of inform us and generate motoric response to tell us what to do about it. And so from that perspective, when we talk about digestion, the brain has a connection to the gut, and that's through the vagus nerve. I'm sure many people have heard of the vagus nerve. At this point, if they follow Dr. Tom and follow the Summit Circle, the vagus nerve being talked about quite a bit, right? Now, for those of you who don't know, vagus nerve is one of the cranial nerves. There are 12 pairs. This is cranial nerve number 10, exit the brainstem, specifically in the medulla oblongata, which is a lower part of the brainstem. And so that the vagus nerve is one of your primary parasympathetic function driver. Now, there are other parasympathetic nerves, right? So like, for example, your cranial nerve number 3, oculomotor nerve, drives tearing response and pupillary constriction, or in a parasympathetic sense, it'll constrict, right?
Well,
So
let's talk about that one for a minute. So the cranial nerve number 3 is the one for hearing. And
for oculomotor, for eye movement.
excuse me.
Yes.
So 3. So how do we access and utilize the vision to increase that nervous system, the parasympathetic nervous system that's designed to relax us? You only heal when you're in a parasympathetic dominant state, which is when we're sleeping, if you have quality sleep, or during the day, if you pray or have meditation or a quiet walk, something that calms you down. How do we use that system of our vision to help support the parasympathetic nervous system?
That's a great question, because there's some application involved here. Before I go into that specific application, I just want to say that the oculomotor nerve, in fact, some of these other nerves that have parasympathetic function, it may have a parasympathetic function insofar as locally, right? So the oculomotor nerve is going to drive lacrimations, tearing. It's going to drive pupil constriction. Does that mean if you get your pupil to constrict, therefore you're going to be more parasympathetic? Probably that function is not as much of a magnitude as the vagus nerve. If you stimulate the vagus nerve, you're going to have a huge systemic overall parasympathetic response. Right. With that said, though, the applications is this. So we know the pupil constrict when you're in parasympathetic, right? When you're in sympathetic fight or flight, your pupil would dilate. Why is that? Because when you're in fight or flight, your pupil dilate to let more light in, so you can see better, perhaps in the dark. So you can see the danger, right? You see what's coming. So in the part of the parasympathetic function to the pupillary muscle is to constrict. So when either pupillary constriction, or sometimes you shine a light in. So we can potentially shine a light in the eye and activate pupillary constriction, and that's kind of firing that oculomotor nerve parasympathetic function. So this is done a lot in functional neurology, where we use it to either diagnose or even address as a rehab, to rehab that particular oculomotor nerve. So for example, if someone has a oculomotor nerve lesion or injury where that nerve is not firing that well, how can we activate that nerve? We can do eye movement that activate the cranial nerve number 3, or we can shine light in, use light therapy to activate the pupillary constriction response. So that's an application there for like neurological rehab. In truth, though, shining a light in your eye is not necessarily going to fire a general parasympathetic response. In fact, for some people who have chronic fight or flight response and lack of parasympathetic, they may lose the ability to really constrict that pupil, right? The pupil might stay dilated, and you shine a light in there, it's just like, whoa, it's just they're sensitive to bright lights, so. Yeah,
we actually, when I first came out in practice, it was one of the tools we used to help identify if a person was in a state of adrenal insufficiency, was you take a flashlight, I'll hold this as if it's a flashlight, and you go into a bathroom without a window, and you close the door, and you come up to the mirror, then you take a flashlight, and you've got it in your hand, you hold the flashlight towards the side of your eye, not in the front, but towards the side, and then you turn the light off. Turn the flashlight on, you'll see the pupils really big, like Dr. Peter said, In the dark, it should be really big so you can see, but as soon as you turn the light on, it should get small. And that's an immediate response, and it should stay small while you're holding the light there. Give it 15 to 30 seconds. And if it starts pulsating while the light's still there, that's a sign that there's not a strong enough response occurring, that you're losing it. And that suggests that you don't have enough of the hormone made by the adrenal glands to close, to constrict when the light comes in. So that was a diagnostic tool we use. And I've had patients for years and years do that test to see if they're in a state of what we call hypoadrenia, or low functioning adrenals, meaning you're burnt out. You know, the stress of life has taken on too big a load for you.
Yeah, that's one of the classic AK, it's in the AK textbooks. It's called a Ragland's response. I would kind of fine tune that, because just remember, there is a sympathetic, parasympathetic function to it. Just simply shining the light in there, it's going to constrict. And you're right, if there's a weakness in the adrenals, the pupils can start to dilate. Think of it as a muscle test. It's a muscle test. If you hold a dumbbell and after 10 seconds, you couldn't hold it anymore, it'll fatigue out. Right. Now, sometimes that can be caused by other things in addition to adrenals, like a oculomotor nerve, cranial nerve number 3, fatigue. Or oculomotor also fires in the mesencephalon. You may be getting mesencephalic fatigue. So then in a functional neurology, then we can have even more diagnostic results that can come from that particular test. But yes, that was a great one. Yeah.
That's a really good point. And that's why you are the expert in brain and nervous system function. That's really good. We have a question from Jane. Great to see you both. Do you know if cataracts can be reversed by diet? I
have no idea. Dr. Tom?
I have no idea. I've never heard of being able to do that. I'm not saying it's not possible, but I just don't know. I had a cataract when I was 44, and it was in one eye, and it's very unusual, and the other eye was perfect, very unusual to have asymmetrical cataract in my age bracket. And I was in the peak of my physical manly years. I was busy working in practice, but I was doing triathlons and I was scoring in the top 10% of 30 to 35-year-olds. So at 44, I'm walking proud, I'm like a hunk of a man, right? In my mind. And I get a cataract, so I'm not so healthy. So what the heck is this? And I asked 3 different ophthalmologists, what causes this? Well, it just happens. And I said, no, it doesn't just happen. What caused it? They didn't know. So I started reviewing the literature, and I found that lead toxicity could cause cataracts. I don't have any lead toxicity. We live a clean life, and maybe I should just check. I had the highest level of lead of anyone I'd ever tested, the very highest. And I said, whoa, really? And when I was a boy, from birth until 8 years old, we lived on 1 block in from the Rouge River in Detroit, and right across the river, on the other side of the river, was the Rouge River Ford assembly line, the largest assembly line of the day back then. And so there was no filters on the smokestack. So I'm living in this area, sucking these fumes constantly 24/7. I'm riding my bicycle around, the neighborhood until I was 8 years old when we moved. And I must have absorbed so much lead at that time and it was in my body for almost 40 years until this was identified. So this person with the cataract, this was Jane on Zoom. Just make sure you do a heavy metal test to see as a potential trigger to where your cataracts may have come from.
I would say that the lead must have, in your particular case, be concentrated completely to one eye and spared your brain, because you're smart as heck. And we know lead lowers IQ. So obviously that had no effect on you.
Well, my teenage years, I didn't score so well in high school. So that may have been part of it, but I was on track. I ran a lot, so maybe I detoxed and flushed some of it out. I don't know, but thank you. Very kind of you to say that. Olga asked the question, what should one do to detox the brain?
Okay, so that's a very good question, and it's also it's also a broad question. Okay, so toxins accumulate in different tissue. Brain is a lot of fat, and toxins, especially metals, are lipophilic, so they like to be attracted to fat. So brain's a very common place for toxins to accumulate. And when toxins accumulate in the brain, a couple of consequences. One is you get inflammation due to reactive oxygen species and oxidative stress that the toxin itself can cause. Secondarily, you can trigger inflammatory response, which is what we're talking about today with the immune system, that you have microglial cells, you have various immune cells in the brain that can start to activate and start to become overzealous and potentially chew up good brain cells. And thirdly, you can have immune reactivity to these toxins, and you get antibody to toxins. So now you have an immune chemical response. Fourthly, you can cause a leaky blood-brain barrier, and now you get even more trouble, potentially developing neurological autoimmunity. So there's a lot of consequence to that. And then when your brain starts to get inflamed, then you're going to have consequence with your gut as well. There's that gut-brain connection. As brain inflammation goes, you get systemic inflammation, and you get gut inflammation, and it comes back to cause more brain inflammation. So you have a loop. So the question is how to detox it. The way I try to do it, clinically speaking, from my experience, okay, I can only share what I do. What I do is I try to help find out whether the toxin in the brain is really the primary driver for that person's symptom at that moment in time, right? Maybe this person's like, oh, I have all this gut issue, I have XYZ, these symptoms. Okay, is the heavy metal toxin or whatever toxin the primary driver of the brain dysfunction? Now, sometimes we can't know that. Is it the primary? Is it secondary? We just we see it all. So if we see the presence of toxins on some kind of test, we also see this person had gluten sensitivity, which really is a toxin too. And then we see barrier dysfunction, leaky gut. And this person is also insulin resistant. And this person also has autoimmunity. And this person is also anemic. Like when you have all these issues, is there a specific order that we should kind of triage this and kind of take this? And so in my opinion, I think there is an order that we should take this. Meaning if they have energy problems, right, fuel delivery problem, they're hypoxic because they're anemic, and they have blood sugar instability. That means that the two primary source of fuel for neurons is already being compromised. So then here you're asking the brain to do even more heavy lifting to detox when the brain itself is unstable, because metabolically speaking, it doesn't have the primary energy requirement. You're asking for trouble, right? It's like asking an injured person to give them like 3 more heavy boxes to lift when this person's already injured. It's not going to do very well. So the question about detox is not whether we should detox. I think we all probably can benefit from detox because the toxins is ubiquitous. The question is, when do we do that? Right? I think that's a better question, because there's no shortage of, resources online on how to detox. And people say, how do you detox brain versus how do you detox liver, or how do you detox? I don't think there's a huge difference. There may be some slight differences, but really what you're doing is you're promoting phase 1, phase 2, phase 3, a detoxification pathway. You're trying to prevent oxidative stress during detox, right? Because the process of detox can drive oxidative stress as well, especially when you go from phase 1 to phase 2 detox, you can have toxic intermediaries. So you want to protect against oxidative stress, and you want to use certain binders, and you want to promote the pathways of elimination. So I think it's pretty universal, right? Like what you might use for those things. But the question is, when do you do it? I say address some fundamental issues, like if you have energy problems, if you have metabolic issues like diabetes, you should fix it first. If you have barrier compromise, I think you should address that first. And once you're all better, and you may be taking someone from a more fragile state, an unstable person, a patient, to a more stable condition and less fragile, stronger, then a detox probably will be more appropriate, safer, more effective. That's my opinion.
That's a really great answer. And everyone can tell that we're dealing with an extremely well-educated doctor who knows that one simple answer can't apply to everyone, right? And so you have to evaluate the person to determine, are we ready to detox? You know, for example, and this is not related to the question, but you never detox a pregnant woman. Absolutely never. You just make sure they're well hydrated so that they can flush as best as possible, but you don't encourage more than what their body has been doing. But I would give one more component to that answer, because this paper just came out. When did this come out? Let me see when this came out. In October of last year in the Journal of the American Medical Association in Neurology. They followed 78,430 adults for 6.9 years of follow-up. So they followed them to see those that walked, how much walking did they do? And they found the magic number. The magic number was 9,826 steps per day. So if you walked 10,000 steps per day, you reduced your risk of dementia by 51%. The only difference was those people that walked 10,000 steps a day, and you get a pedometer. It's easy enough to get there. They're not expensive anymore. And you just make sure that you're doing walking regularly. And the magic number was 9,826 steps per day. And you reduce the chance of dementia, which I would make an assumption is because you're also helping to detox the brain. I would assume that's part of, you're detoxing the whole body when you're moving like that, including the brain. But that's something for this person who asked the question. I don't quite see who's, it was Olga on Zoom. That's something that you can begin immediately, Olga, is just starting to walk more every day. You don't have to run, you don't have to jog, you don't have to swim, you don't have to do triathlons. Just walking on a daily basis can help quite a bit. Lorraine's asking the question, what can cause essential tremor, shaking when trying to move hands? Is there a cure?
So she's saying essential tremor. And so essential tremor is basically a type of tremor where, they're saying like, we don't know what's causing it, right? You just have a tremor. Now, if we really get into the nuances, there are many different types of tremors. There's, action or movement-based tremor. There's resting tremor. There's hyperkinesia. So there's different types of tremor. And clinically speaking, what's very common is action-based tremor, meaning a tremor that comes when you're actually moving. So for example, if I were to reach for a piece of paper and I'm holding a piece of paper, and then you see that the paper is shaking, or sometimes you are at a restaurant, the waiter or the waitress is handing you a drink and the water's shaking. So that might be that's more of an indicative of an action-based tremor. Now, right. Action-based tremor.
Her question was shaking when trying to move hands.
There you go.
So it sounds like an action-based tremor.
If it's tremor, so the difference is if it's shaking when she's moving and when she just rested on her lap, there's no tremor, then that's more of a action-based tremor. Typically, the cerebellally based. Mm-hmm. If it's a resting tremor, where it's shaking even when you're just having your hand resting on your lap, and it's a pill rolling tremor, that may be basal ganglionic tremor. Could be Parkinsonian in nature, could be medication side effects, could cause hyperkinesia, tardive dyskinesia. So I think, obviously, having a physical exam by a doctor who knows what they're looking at can help you to identify what it is. Cerebellally based tremor is, if you're going to have I always laugh when people say this, if you're going to have cancer, this is the kind of cancer you want to have.
Right.
If you're going to have tremor, the cerebellar tremor is what you want to have because it's more receptive to being rehabbed. You can fix it a lot easier. Basal ganglionic tremor, typically not so much. It's a lot harder.
I fully agree. And Lorraine, I would add to that, in my practice, I did 316 consecutive patients with a very comprehensive blood test. looking for antibodies to different foods and to brain. And one of the tissues was cerebellar tissue. And we found that, and if a person didn't want to do, I don't care what they came in with, between the age of 2 and 90, and everyone got this test. And if they didn't want to do the test, I said, all right, here's a list of 2 other doctors in the area who are really good doctors. But, this is part of our research right now, and I think it can help you. Okay, I'll do the test. 68% of everyone, irrespective of what they